Good afternoon and welcome. My name is Kathleen Borain and I serve as the Maryland Insurance Commissioner. The purpose of today's public hearing is to discuss the draft revisions to the Maryland Insurance Administration's network adequacy regulations that were posted on the MIA's website on July 7th, 2022. We have received a number of comments. Although at the request of a number of stakeholders, we did extend the deadline to make comments until today. So we are still receiving comments. We also have a number of people who have pre-registered to speak, and we'll have the opportunity to hear from each of them a little bit later during the meeting. Also, if you want to speak, but you did not register to speak, if time and technology permit, we will try to hear from everybody who has something to say today. I'm going to start the meeting by apologizing because I just spent the last week at the NAIC, and I am hoping that I did not bring a little friend home with me, but I'm afraid that I may have. So being a little bit under the weather and my voice being a little taxed and coffee, I am going to ask David Cooney, who is our Associate Commissioner for Life and Health, to run this meeting. I am going to go off camera, but please understand that I'm sort of doing that to spare you, my voice and watching me hack. But I am listening and I am engaged. And because I'm me, you may find me zipping in to ask a question, but for the most part, I'm going to ask David to please run the meeting today. And as I go off camera and on mute, I just want to say to everyone how thankful I am for your engagement and the comments that we have received so far. And I look forward to what I hope is going to be a robust, but a very productive discussion today. So thank you. David, I'll turn it over to you now.
All right, thank you, Commissioner. Of course, we all hope you feel much better very soon. So I'm going to begin with an overview of the draft revisions, and then after that, we'll accept public testimony from all interested stakeholders who wish to give comments. But before we start with that, there's several MIA staff members who have joined me this afternoon, and I'd like to take a moment to introduce them. So we have Mary Quay, the Associate Commissioner for Market Regulation and Professional Licensing.
Good afternoon.
We have Brianna Davidson-Jarrett, Assistant Attorney General.
Good afternoon, everyone.
Lisa Larson, their Director of Hearings and Regulations.
Hi, everyone.
Paul Meyer, Special Projects Analyst for Life and Health.
Good afternoon, everyone.
And then Pamela O'Brien, our Network Adequacy Analyst. And then helping us out today with the logistics are Joe Sfiatko, our Public Information Officer, and Suzanne Forno, our Public Relations Specialist.
Hello, everyone.
So stakeholders will recall that the last public draft of the proposed revisions to the network adequacy regulations were released back on November 4th, 2020. There was robust discussion of those regulations at 3 different public meetings in late 2020 and early 2021. And many stakeholders also submitted written comments about the prior proposal. The MIA carefully considered all the public comments received, and we began incorporating further revisions into the draft as appropriate. Public work on the network adequacy regulations was then temporarily put on hold in mid-2021 during the time when the MIA's regulations related to the mental health parity reporting needed to be prioritized to ensure they were in place prior to 2022. Internal work on the regulations continued in 2022, and many of the additional revisions included in this latest draft were informed by the MIA's experience reviewing carrier access, network access plans, and identifying trends in carrier compliance and some persistent challenges with the existing regulations. The most significant amount of time was devoted to researching how telehealth can appropriately be used to enhance and support network adequacy. In developing the new telehealth proposal that you see in the current draft, the MIA considered the requirements of the Preserved Telehealth Access Act of 2021, the experiences and best practices of carriers in Maryland, comments and concerns raised by stakeholders, approaches taken by other state and federal regulators, and available national and state data on telehealth. So we are welcoming public comments on the telehealth proposal and on all the other draft revisions as well. Once we have taken all your comments into account, we plan to formally propose these revisions in the next few months, and we hope to finalize the regulations close to the end of the year. So before we do open up the meeting to the public testimony, I'm going to provide a brief overview of the new draft regulations. Much of the regulatory changes that are shown in the new July 7th draft were previously included in the prior November 2020 draft. Those changes were discussed extensively at those prior public meetings, and we received written comments on the changes as well. So for today, I'm really just going to summarize the items that are different from the 2020 version. The first section you'll see in the draft is Regulation 02, the definition section, but no new changes were proposed for that section. The next section is Regulation 03. This regulation establishes the broad overarching standards for network adequacy, and it was a newly proposed regulation in the November 2020 draft. Many of the changes in the current draft were simply to clarify the intent of existing language based on comments we received from stakeholders, or organizational changes to relocate requirements to different parts of the regulation where it seemed more appropriate. There are, however, a few more substantial changes in the section I'd like to highlight now. There was a new reporting requirement proposed in the prior draft for the number of board certified providers in the network based on national board certification. In the current draft, this was changed to a tracking requirement that now uses the designations from Maryland's Uniform Credentialing Form, and the information is only required to be submitted to the commissioner upon request. We also added new retention requirements related to all the policies and procedures required by the regulations. And we reduced the frequency of the required internal compliance audits from monthly to quarterly. And this new timing will be more consistent with the frequency that carriers are required to verify and update their provider directories under the Federal No Surprises Act. Moving on to Regulation 04, filing and content of access plans. This regulation had some of the most significant changes from the November 2020 draft. Our ongoing reviews of the annual access plans revealed many areas where data and information was lacking in order to enable us to fully evaluate network deficiencies. Whereas the statute already requires the access plans to include a description of various carrier processes and efforts, the descriptions initially provided by carriers in their access plans have been very vague in general, necessitating many follow-ups from the MIA. So the new standards illustrate some of the types of initiatives we would expect carriers to engage in, especially if there are noted deficiencies in the network or challenges in accurately measuring adequacy. However, the regulations do not at this time require establishment of particular policies and processes. They simply require reporting of any existing processes that the carriers already have in place. Additionally, while we grant that the new data reporting requirements in this section are significant, there was much internal discussion to attempt to limit the required data elements to items that would be most useful in helping to identify potential areas of deficiency. The new draft requests specific information on out-of-network claims and complaint data related to availability of providers, which, while it won't necessarily indicate a network deficiency, it will at least provide greater insight into areas where further investigation may be warranted. The last change in this section that I want to highlight is that we removed the separate reporting requirement for facility-based providers in the network. We received comments from both the facility-based providers and the carriers that this information would be difficult to track and accurately report. And since the Federal No Surprises Act now protects consumers from balanced billing in these situations, this data point appeared less critical for us to gather as part of the network access plan reviews. The next regulation where you'll see revisions is Regulation 05, which is where the travel distance standards are included. Most of the changes in this section were in direct response to public comments received in the last draft that the administration agreed with after further consideration. So I just want to highlight two of the revisions from this section. The first is that we added a requirement that the supporting documentation carriers must submit to justify the travel distance metrics. It's now going to be required to include a calculation of the average distance to the nearest provider for all enrollees in a zip code where the distance standard is not met. This is information that some carriers previously voluntarily provided this information in their access plans, and we found it to be a helpful data point to evaluate just the extent of certain deficiencies in the access plans. We also added a new specific distance standard for residential crisis services providers, because this is a mandated benefit in Maryland, and we continue to hear that there's a dearth of these providers and carrier networks, even though the mandate has been on the books for many years. The next regulation is 06, where the appointment waiting time standards are described. In this section, based on consensus public comments from carriers and healthcare providers that quarterly wait time surveys would be too burdensome, we reduced the frequency to semi-annually. Also, because we added a completely new section that addresses telehealth separately, we are no longer proposing the revision to the telehealth language that was included in the November 2020 draft, and are instead repealing all of the current language related to telehealth that currently appears in the appointment wait time standards section. We also removed language from the proposed November 2020 draft that would have directly tied the reported median wait time metric to the travel distance standards. Upon further MIA consideration in response to a carrier comment, it was determined that this requirement would have been too difficult, if not impossible, to operationalize, because the wait time standard is not actually measured at the member level, unlike the travel distance standard. Network-wide compliance with the wait time standard is determined based on member surveys and direct provider contracts that ask for the next available appointment in general. Because this method of calculating data focuses on appointments in general, it does not allow for analysis of the distance between the patient, an individual patient, and the provider. So when investigating a complaint for an individual enrollee, the MIA would, of course, consider both wait time and travel distance together when determining whether the carrier has provided access to an in-network service. However, it is currently not feasible to do this when determining compliance for wait times across the entire network. And finally, there were several technical corrections in this section that you will see as well. Regulation 07 addresses provider to enrollee ratios. The only new revisions in this section were corrections to typos. Regulation 8 is our telehealth section. So this is a completely new section that is intended to encourage carriers to use telehealth to enhance and support network adequacy in a meaningful way. As we mentioned at the top of the meeting, we considered all available information and resources while developing this proposal, and we particularly considered the requirements of the Preserved Telehealth Access Act of 2021. Our research found that many carriers, providers, and regulators are still evaluating how to best leverage telehealth in the network adequacy arena. So there was no single best practice identified in the insurance market right now. However, with state and national research demonstrating near universal support for the general idea of leveraging telehealth to enhance access to care, particularly after regular office hours, and with insight we have gained from our own experience with network adequacy over the last several years, we determined that positioning Maryland as a leader in this area was warranted, and that doing so would be preferable to the alternative of sticking with the existing telehealth language in our regulations, which we found provides no real incentive for carriers to invest in telehealth. The telehealth proposal you see in the draft regulations requires carriers to report on telehealth utilization data, and it allows carriers to request a credit toward meeting the travel distance standard and wait time standards based on a demonstration of enrollee access to clinically appropriate healthcare services. For travel distance, we looked very closely at the telehealth credit that is currently available in the Medicare Advantage market, as Medicare Advantage seems to be the sector where regulators have taken the most proactive approach with telehealth to date. We were concerned with the Medicare approach, however, because it awards a blanket credit toward the percentage of members who reside within the maximum travel distance standard, simply because a carrier contracts with telehealth providers for particular specialties. One of the main problems we saw with this approach is that it does nothing to ensure that the enrollees to whom the credit applies actually have access to telehealth services. I mean, as a very simple example, if the carrier has a deficiency for a particular provider specialty in a certain geographic area, and if there's no broadband access in that area, then even if the carrier contracts with telehealth providers for that specialty, the carrier is not actually addressing access for those particular enrollees in the impacted region. So with this in mind, we have proposed a credit that, when awarded, increases the maximum number of miles permitted to the nearest provider in zip codes where the carrier offers telehealth, but fails the otherwise applicable standard. The credit may only be applied toward a maximum of 10% enrollees for each provider in each geographic area. The idea with this proposal is that if a carrier offers telehealth, and if they can demonstrate, one, that telehealth is appropriate and actually utilized for the specialty in question, and two, that telehealth services in general are actually available, accessible, and utilized in that particular geographic region, then the carrier is permitted to require members to travel a little bit farther to receive in-person care when the carrier is unable to contract with a provider with a physical office location inside the otherwise applicable distance standard. The proposal deliberately avoids unreasonably using individual consumer preference as the sole determinant of whether the credit is granted, while at the same time addressing, with respect to telehealth services in general, both accessibility of telehealth services and consumer willingness to elect telehealth, and with respect to the specific specialty or appointment in question, consumer and provider overall willingness to accept telehealth. It's also very important to note that the credit is subject to approval by the commissioner, which allows the MIA to exercise discretion in granting the credit depending on the circumstances and documentation for each filing. For wait times, we took a similar approach. However, due to the way the wait time metric itself is calculated, it will be more difficult to obtain documentation from carriers that shows telehealth is actually accessible and available to the particular enrollees who experience longer wait times. So for this reason, the wait time credit is partially contingent on requiring carriers to explain how they help individual consumers who are unable to obtain a timely appointment and for whom telehealth is not appropriate or accessible. The regulation then explains the types of documentation that will be considered by the MIA when determining whether telehealth is actually appropriate, available, and accessible for the standard where the credit is being claimed. I want to emphasize that the proposal does not remove the requirement for carriers to provide coverage for in-person services under their contracts for all enrollees and all covered benefits. It merely provides that for the purposes of determining adequacy of the network as a whole, in very limited circumstances, the network will be deemed compliant when clinically appropriate telehealth services are available, even if certain consumers must travel a little bit farther or wait a little bit longer to receive in-person services. Additionally, the strict documentation requirements and the 10% cap we included will help ensure that carriers do not use the telehealth as a substitute for maintaining a sufficient network of brick and mortar providers. We feel that the proposed approach appropriately balances the undeniable potential for telehealth to address network deficiencies with the need to protect the rights of individual consumers to choose in-person services if they prefer. And moving on to the next regulation, just a few more brief comments. The regulation 09 is where the network adequacy waiver standards were included. Minor revisions were made to the waiver standards, either due to public comments or to address issues noted during review of access plan filings. For example, language was added to make it clear that carriers should be analyzing and attempting to address the reasons why providers are refusing to contract with them, and also that carriers may submit information on any additional mitigating factors for consideration by the commissioner, including limitations or constraints on the measurement methodology for the standards. Regulation 10 addresses confidentiality, but no additional changes were proposed here since the November 2020 version. Regulation 11 addresses the network adequacy access plan's executive summary form. The requirements here, they were tweaked just to clarify how the data should be organized. And then requirements were added to explain how the telehealth credit should be captured on the executive summary if the carrier claims the credit. The regulations require the carrier to provide a disclosure of where and how the telehealth credit was applied, which will allow the public to compare the performance of plans that use the telehealth credit with plans that do not. And that it completes the summary of all the changes we have here. So at this point, I think we're ready to open it up to our registered speakers. A number of people requested to speak in advance. If there are others on the public call who would like to speak, you can let us know in the chat function. And as long as the commissioner mentioned earlier, if time permits, we will be able to turn to you after we hear from all our registered speakers. So our first registered speaker for today is Lori Doyle, Public Policy Director of the Community Behavioral Health Association. Welcome, Dory. Welcome, Lori. Please speak in whenever you're ready.
Thank you, Associate Commissioner. It's good to see you. Lori Doyle, on behalf of the Community Behavioral Health Association of Maryland. CBH represents 105 organizations providing mental health and substance use disorder treatment and support services in the community. We really want to thank and commend the MIA for these proposed regs. They represent, we think, a very great step forward in providing accountability regarding access to behavioral health treatment in the commercial sector. We strongly support the proposed travel distance standards and the inclusion of specific behavioral health practitioners, for instance, child and geriatric psychiatry, and facilities such as outpatient mental health clinics and outpatient substance use disorder programs. We are also very supportive of the wait time standards for urgent and non-urgent inpatient and outpatient mental health and substance use disorder treatment, because really wait times are the gold standard in behavioral health. Timing is everything. So when people are ready for change, they need to have access to the services. To delay means there could be worsening of symptoms and functionality and very bad outcomes such as suicide and overdose. We know there are issues with timely access to specialized care such as child psychiatry. So we're glad to see that this is addressed in the language, that the appointment has to be with, quote, a provider possessing the appropriate skill and expertise to treat the condition, end of quote. We're also very gratified to see the inclusion of travel distance times for residential crisis services, as you mentioned. RCS are designed to provide an alternative to ED and inpatient utilization for those experiencing or at imminent risk of psychiatric emergency. They provide the same level of psychiatric care found in an ED, but in a much less chaotic setting. We know from hospital association data that there's an overutilization of EDs for behavioral health emergencies. We also know from MIMS data that psychiatric patients account for the lion's share of boarding time in our EDs. So there's a front door and a back door problem that RCS can address. We are supportive of the out-of-network reporting. We know from past Milliman studies that Maryland has one of the worst records in the nation for use of out-of-network services for behavioral health, and that impact on consumers can be significant in terms of cost sharing and delays in treatment. And finally, addressing the telehealth standards, we appreciate the balance the MIA has brought to the use of telehealth and its use in meeting network adequacy standards. We're very strong supporters of telehealth and its ongoing flexibility for its use. However, we think that must be balanced against the need for access to in-person services. So behavioral health, we think, is a little bit different from somatic. So normally when you think of something being clinically appropriate in somatic care, the clinician determines, can I listen to this cough via telehealth, or can I look at this skin condition and make an assessment and diagnose this condition? Behavioral health, the individual, the patient or the client brings the same amount of determination to that clinical appropriateness. So it relies on that person's comfort level with both the clinician and the service modality, since it's very personal disclosure of mental health status that drives the whole ultimate diagnosis or treatment. So if the client feels unsafe, perhaps because of concern that telehealth isn't private enough, then the client will not be forthcoming about her mental health status. So we think in behavioral health, clinical appropriateness is a determination that rests as much with the client as it does with the practitioner. We would therefore urge that the term clinically appropriate be defined to include a member's willingness to engage in telehealth, at least for behavioral health. We further suggest that those requesting a behavioral health appointment be given the opportunity to choose telehealth or in-person services, and that telehealth not automatically be allowed to suffice for in-person care. So in closing, I just want to thank the MIA. We strongly support the proposed regs on network adequacy, and we look forward to working with you and the insurance carriers to ensure timely access to behavioral health care. Thank you.
Thank you very much, Lori. Does anyone on the MIA have any questions for Lori before we move to the next speaker? Okay, so next up we have Ellen Weber, Vice President for Health Initiatives at the Legal Action Center. Welcome, Ellen.
Thanks so much, David. And Commissioner Burgin, I do hope you're feeling better quickly. Again, thank you so much for the opportunity to provide comments. We have submitted extensive comments on behalf of the Legal Action Center and a number of members of the Maryland Parity Coalition. And Obviously, we are not going to run through those in detail. They are extensive. We thank you for thinking about them, and we really urge you to adopt all of those recommendations. What I wanted to do is spend a few minutes, maybe a little more than a few minutes, identifying what our top items are. And so we'll try to do that as quickly and as efficiently as possible. We tremendously support all of the additional information that the MIA is going to is proposed to gather through the access plans. It requires a significant amount of work on behalf of the carriers, and we want to ensure, obviously, that policymakers have access to all of that information. And so what we're doing is we would request that the MIA make that available to members of the General Assembly and to the public in the form of aggregate data reports. Not only is it important for members of the public, but it's also really important for employers who use this information in determining which plans they want to purchase for their workforce, knowing that individuals have significant needs for mental health and substance use disorder care, and therefore have to make some very critical decisions as to which plans are really going to deliver that care and have providers available for those purposes. We wanted to also suggest that based on all of the experience the MIA has had in the last 5 years, the use of standardized reporting tools and methodologies for all of the data points that you are now requesting in the access plan seems to be an important thing to do. So again, you've just recounted, David, that you're bumping up those access plans because there's information that carriers haven't reported with sufficient detail. We think the best way to get sufficient, uniform, and accurate detail is to have uniform forms and methodologies for that purpose. So that's sort of our first bucket of requests. We also very much support and appreciate the additional granularity of information, particularly with regard to mental health and substance use disorder services for both the appointment wait time as well as the travel distance standards. We have supported that for the entire period, and thank you for retaining all of those. We do oppose, however, and this is something that we noticed in this go around of review and failed to notice it in previous comments. We very much oppose in your summary form the removal of the percentage of satisfaction for appointment wait time, as well as the indication of what the required metric is. The requirement would now report, the summary form would now require reporting of the median wait time, which will mean absolutely nothing to consumers. They will have no idea as to what the requirement is. And what they really want to know is, how does that measure up against what the metric is that's required, what the value is, right? So we urge you to correct that and to retain the current standard that exists in the regulations. We also had a question as to whether or not in that summary form, the reporting that's being done is with regard to in-person appointment wait time, or whether that is some other value. We note that on the revisions to the appointment wait time standard itself, it requires reporting for in-person services. And we believe strongly that that's what should be reported on the executive form. At a minimum, if you want to require reporting of both the in-person and telehealth visits, do that as you have done with regard to the travel distance. You are making a distinction as to the standards that are met with telehealth versus without telehealth. And we think that consistency should be provided with regard to appointment wait time. So that's sort of a second bucket. And again, our failure to note that in previous comments in terms of that change of standard, what's getting reported in the executive form, that was our oversight, and hope that in no way indicated that we consent to that or we agree to that. We very much oppose that provision. And then I wanted to talk a little bit about the credit. We believe and have always believed that telehealth should be counted for purposes of meeting network adequacy standards. And that standard has been in place for appointment wait times for the past 5 years. That has always been permitted, and we don't recommend any change with regard to that. We also would probably approve of applying a credit to travel distance. But the experience over the past 5 years, the experience over the Preserve Telehealth Act, and all of the data that we're gathering demonstrate that it is the consumer that has to be at the heart of that decision. That is what we heard consistently from both the providers and the payers at the Maryland Healthcare Commission's town hall meetings. It is what is being identified in NCQA reports with regard to health equity, that it is the consumer that is at the heart of that decision-making process in collaboration with their provider. And therefore, in our view, it is inappropriate to remove consumer election as one of the criterion for determining whether or not telehealth should be counted for purposes of appointment wait time metric as well as travel distance. We know that 2 carriers in the 2020 network adequacy reports have reported out data that satisfies the current standards of consumer election for purposes of counting telehealth for their appointment wait time. So for us, there just seems to be no reason that that cannot be done across the board. There can be the online directories and searches can query members when they're selecting appointments. There can be other types of surveys that gather that data. It would be very interesting to learn from Kaiser as well as United as to how they're making that determination. If they can do it, other carriers can do so as well. At a minimum, we would agree that with Ms. Doyle that clinically appropriate has to be defined to take into consideration consumer election and consumer choice. So that's sort of the third bucket of concerns. The fourth bucket of concerns relates to the telehealth credit itself. We are very leery of giving an artificial advantage to carriers that is not tied to actual performance and does not on its face require the availability of in-person services for those who want them. We are very gratified to hear in your overview that this in no way removes the obligation to provide in-person services, but one would not know that from reading either the telehealth credit or looking at the information that is to be included on the executive summary form. And we think those are 2 significant oversights that puts a thumb on the scale for telehealth. We are in no way objecting to the use of the telehealth. We know how valuable it is. But at the same time, the data that are available clearly indicate that over 50% of visits over the course of the pandemic for mental health and substance use disorders are still in-person services. And it varies pretty dramatically by the type of mental health or substance use disorder condition that's being treated. And therefore, to in any way undermine that right that exists in Maryland law and to not make that critically clear is a significant oversight for us. We appreciate the description that you provided with regard to how you arrived at the particular telehealth credit for travel distance. We are though still confused, or at least I'm still confused as to how one will arrive at a percentage of satisfaction of appointment wait time under this model. There is no guidance on that, obviously, and there's no indication of what percentage of satisfaction one would award under any given circumstance. So that data point is just quite opaque for us. We also, quite frankly, oppose the use of the development of the use of a telehealth credit at least a year for at least 1 year while data is still being gathered. We had, again, a telehealth credit essentially was in place since the beginning of these regulations. 2 carriers have now reported out information that indicates that they're actually gathering data on that. Now we know they must be, but only 2 have done so far. So for us to be putting a standard in place at the end of this year and allowing carriers to at least claim a credit in the next go around seems to us to be fairly premature. We also, again, based on your description, it appears that if the carrier satisfies these metrics using the telehealth credit, they will no longer be subject to any enforcement penalties. And it also appears that they won't be subject to the requirements to submit the waiver information. Again, that to us is a critical loss of information and a critical loss of any incentive for the carriers to provide in-person services and to build robust networks. The waiver requirements we were and are continue to be very supportive because they're now mandatory and they will require the carriers to identify what their efforts are. But if with a telehealth credit, they no longer have to submit those waiver material information, all of that detail is lost really to really understanding why networks are deficient for a number of reasons. And so again, we very much oppose the removal of those two requirements and tying it to the satisfaction of and use of a telehealth credit. So that's the fourth bucket. And thank you for your indulgence. The final bucket is, as we've said early on, we truly believe that the carriers must be required to inform members of their right to in-person services. That should be included front and center on the executive form. And the statement that is being permitted right now that a more timely appointment could be available through telehealth, that to us may be false, obviously, but based again on information we've heard in the town hall meetings. But bottom line is, it completely puts the finger on the scale of telehealth. There are already carriers that are steering individuals to all telehealth platforms without any kind of knowledge that the member has a right to an in-person service. That again is just, is not full and accurate disclosure. So we urge you to identify that right, make it front and center and available on the executive form. We also believe that one way to address this is in provider directories to require the provider directory to identify very clearly whether a provider is delivering in-person services, whether they will deliver only telehealth services, or whether they will provide a hybrid service. And if they're providing telehealth only, to identify the state and zip code in which they're located, because that's going to be a critical point of information for individuals who will more likely than not want to have a hybrid system of care. That's what we learned again in MHCC's town hall meetings. And we have no reason to believe that that's not going to happen in Maryland. Again, one last conclusion. We believe Maryland is a leader in how to use telehealth for purposes of network adequacy. They have been a leader for the last 5 years. They've allowed telehealth credit to be used for appointment wait time satisfaction if a member elects it and if it's clinically appropriate. No reason, I think, to adopt another standard right now. There are many states that don't allow, some states that don't allow telehealth to be considered at all for satisfaction of network adequacy. And we urge Maryland to, again, gather the data and not get ahead of itself in a way that would, in our way, undermine full and robust networks. So thank you again for letting me share those comments. Happy to answer any questions.
Sure, thank you, Ellen. And obviously, as you said, they're very extensive comments, so it'll take us some time to get through all those, and we may have questions later. I can just answer quickly one of the questions you posed during your testimony there, just for clarification, the executive summary, the wait time information that needs to be reported in the executive summary, that is limited to in-person visits, just as the standard itself is. So like I said, we'll digest and all your other comments as well, but that is something I could tell you off the top of my head. Does anyone from the MIA have any questions for Ellen at this time? Okay, thank you again. Let's go on now to Barbara Mercado, who's representing various healthcare provider and physician clients. Barbara, welcome today.
Thank you, David. Thank you, Commissioner Burgin and everyone there at MIA. I'm going to be brief and then David turn it over to my partner, Dan Shattuck. But I want to be, I'm being redundant, but sincere in saying that on behalf of our providers that go from behavioral health, substance abuse to emergency medicine, anesthesia, surgical subspecialties, physical therapists, dietitians and nutritionists. We are very supportive of these proposed changes and want to share our appreciation for your efforts to develop regulations that will help Maryland continue to move forward in developing more and more robust networks, particularly in light of the current environment. And there's been discussion in reference to the intersection, so well put by the previous speakers, but the intersection of telehealth, audio, virtual, in person, and how that needs to be implemented in a way that the patient and the provider are making the best decisions, and it not being a financial kind of step therapy process that is interferes with that kind of decision making. But I also want to dovetail this discussion with Maryland's law on what we call the assignment of benefits law, which really has, I guess it's been in effect about 10 years now, and some on this Zoom were very involved in the development of that statute, including Dan and myself. And when that statute passed, or before it passed, the out-of-network participation rate for our hospital-based physicians was, I think, around 26, 27%. And in the most recent public study that the Maryland Healthcare Commission did, our in-network rate was below 4%, as about 3.6%. And so it was tremendously successful in bringing the providers and the payers together. And that is what is fundamental. Our experience with the providers is they never want to be out of network. They absolutely want to do everything possible to be in network. So I have to say, Laurie and Ellen were both eloquent in talking about behavioral health. And I want to mention a few things, particularly for our emergency physicians, anesthesiologists, in particular about, the data collection that you are going to include here in terms of the hospital-based physicians. But looking at the fact that the hospitals are in network, and we want to do everything possible to have the insurers contract with the hospital-based physicians. And I think we want to talk with you about looking at distance standards and, moving these specialties into that kind of umbrella where there are appropriate standards. So having said that, David, I'd be glad to try and answer any questions or turn it over to Dan, because he's been involved in this since before the law was passed and during that process. So he's much more well-versed than I am.
Sure, thank you. Thank you, Barbara. I think we'll go to Dan, and then if anyone has questions for either one of you after that, we'll take those questions then. So yes, go ahead, Dan, please speak whenever you're ready.
Thank you, David. I too just want to echo and say thank you to the commissioner and the MIA for this important and very thorough discussion and process. I think it's already been highlighted today from the provider point of view, how important network adequacy is, how important transparency is. As Barbara noted, we're here today on on behalf of a number of our clients, many of whom have submitted written comments. And we just wanted to touch on some of the unifying themes throughout those comments. And again, it's echoing what's been said, but it's fundamentally important that the physicians and providers are represented on carrier networks. Keeping an in-network status is tremendously helpful, not just from the administrative side, the provider-carrier relationship, but for the enrollees, the subscribers, or the patients, however we want to refer to them. But that's the key. Life is easier for them when they're accessing their insurance and they know that their networks are going to cover every aspect of care, whether it's PTs and dietitians and nutritionists or emergency medicine and anesthesiologists. It's true that they're in those in-network hospitals, but we're also saying there needs to be a look at making sure that they're brought into the networks as well. And even in instances where some of those providers aren't just hospital only, but they might work in other areas outside of the hospital and surgery centers and so forth. So that's an important consideration to look at. Also, the data reporting that's been added in these regs, looking at the out-of-network experience, especially given the No Surprises Act and the MIA's role in working with CMS, and finding where Maryland law covers and where Maryland law doesn't. It's, I think, essentially helpful to start collecting this information, and then to the extent that it can be made available, all the better. Looking ahead as we navigate the coming changes to the healthcare delivery system in future years. And then just in the telehealth range, a lot's been said. I wanted to echo Ellen's comments and acknowledge your comments, David, about the importance that telehealth won't supplant the brick and mortar arrangements and participation in network, but we want to make sure that the language in the regulation is clear on that. I think it's inherent, but we just want to make sure that it's clear. And also that the provider-patient determination of when telehealth is appropriate is really a significant factor that I think needs to remain. Ultimately, it's that clinical decision-making that is so essential to decide what tool would be best for that patient, whether it's a virtual visit, audio only visit, or if it's that time in the office. And for each provider and physician group out there, it's going to be a little bit different what can and can't effectively be done. And then another point, and I think this was raised as well, but my recollection is in the law that passed in 2021, I think it was House Bill 123, that maintains some of the enhanced telehealth modalities and services until 2023. There was language in that bill that made it clear that carriers couldn't direct enrollees to third-party platforms as a condition of coverage. And I was wondering if that would be something that could be reflected in these regs as well, that who they're interacting with on a telehealth basis is important. And we don't want to make telehealth become a barrier or a hurdle that patients might have to overcome when trying to get the care that they need. So with that, I'll wrap up my comments. I'm happy to answer any questions. And again, thank you for your time and effort on this important issue.
All right, thank you very much, Dan. Does anyone at the MIA have any questions for either Barbara or Dan? All right, well, thank you both again. Okay, let's see. Next, we have Barry Ziman, Director of Legislative and Political Affairs for the College of American Pathologists. Barry, welcome.
Thank you. Thank you, Associate Commissioner, for giving us the opportunity to comment on the regulations. First off, I want to say that I'm speaking today on behalf of College of American Pathologists, the Maryland Society of Pathologists, and we are co-signers to the submission made on August 10th of the Maryland Medical Society, which was signed by a multitude of hospital-based physician specialties, expressing concern about the lack of specificity in this draft of a network adequacy standard as it is applicable to hospital-based physicians. The prior draft that was issued by the department in November 2020 had some specificity that has now been omitted. And we think that the history on this may be a little bit misconstrued by the department. Hospital-based physician coalition, anesthesia, radiology, pathology have submitted comments going back to 2017 on this issue and urging the department to assess health plan network adequacy for hospital-based physicians. to ensure that when a health plan markets itself as having XYZ hospital in network, that they have in fact undertaken the due diligence to actually contract with the critical physician specialties at that facility. Otherwise, we think it's commercially deceptive to consumers to indicate that you've got a hospital in network and you haven't contracted with the key specialties at that facility. Our position, as I said, goes all the way back to 2017 in comments to the department. And in 2017, the Maryland Attorney General's office actually echoed our concerns about the lack of specificity in the regulation as it relates to the specialties I mentioned. So we do stand in strong support of the comments that have been submitted by the Maryland Medical Society, which urges the department to specifically include in the network adequacy standards reference to the specific hospital-based physician specialties that I mentioned in order to ensure that the plans are actually contracting with those specialties. In the intervening years since 2017, I'd also point out that several states, Washington, Virginia, New Hampshire, and Louisiana, have all enacted laws requiring in statute their insurance departments to scrutinize health plans for network adequacy as it relates to hospital-based physician specialties. And it's the opinion, I think, of medicine, of organized medicine, that the necessity of this has not been obviated by the federal enactment of the No Surprises Act, nor any state laws that provide for out-of-network payment methodologies. As was pointed out by prior speakers, we think it's an imperative necessity from the consumer perspective that these specialties be in network. We want to ensure that consumers and enrollees are getting timely access to these specialties when they're going to hospital and facility-based providers. We're concerned that if their services are not in network, that there could be delays and untimely provision of services or some other encumbrances on enrollees if these physician providers are not actually in network. And as I mentioned before, we also think it's to some degree commercially misleading to consumers when they're relying upon directories and other marketing materials from plans and assessing which plan they want to choose if they're not informed regarding the status of these specialties at in-network facilities and hospitals. So again, we would urge the department to very seriously and very carefully consider the comments that have been submitted by the Maryland Medical Society on behalf of all the specialties, and I'd be happy to answer any questions.
Thank you, Mr. Ziman. Does anyone at the MIA have any questions? All right, well, thank you again for your comments, and we will absolutely consider those written comments as well.
Thank you.
Okay, let's say next up we have Courtney Burgin, who is a member of the Maryland Parity Coalition. Courtney, welcome.
Hi, thank you so much for all the work on the proposed regulations. I mostly wanted to just speak to what a lot of what Ms. Weber already spoke to, but specifically concerns on the telehealth credit. Just based on even personal experiences I've had trying to access in-person care on my own carrier's network. I do believe telehealth should be counted. I think it's really important to cover telehealth and include it in network adequacy considerations, but I also think that we need to make sure that carriers are not artificially, their networks are not artificially being inflated by either steering people to telehealth, by allowing that to count when perhaps an in-person visit may not be available or when it's not clinically appropriate. And as both Ms. Doyle and Ms. Weber stated, it's really critically important that consumers' choice is considered in determining what is clinically appropriate, particularly when it comes to mental health and substance use disorder services, just because of the need for trust in forming a therapeutic alliance. And so I believe that awarding a blanket credit for telehealth without accounting for specific consumer choice can be really detrimental. I think it's really important that that is somehow accounted for in many of the suggestions that Ms. Weber stated, whether it is including that in provider directories, whether there can be a question of how do you want to receive care when consumers are contacting insurers for help with locating care. As I said, I had a personal experience where I was seeking in-person care. I made that very, very clear to the carrier, and I was still directed to a telehealth provider, and that telehealth provider was located out of state. They were licensed in Maryland, but not practicing in Maryland at the time. And for me, that would have been really problematic because I needed that hybrid model of care. I use telehealth and I really appreciate it, but it's really important to me to have that in-person care available. And I'm really concerned that if there is a blanket telehealth waiver that can either increase wait time and or travel distance standards and make that permissible, it's going to have a disparate impact on people who are already marginalized and create an even bigger health equity issue, particularly people with significant mental illness, significant substance use disorder conditions, where they already have so much difficulty obtaining care in the first place. And so I think for that reason, I really oppose the credit and think that there needs to be some accounting for individual elections for what the type of care people are seeking. And I think it's really important that we somehow support an integrated hybrid model of care rather than putting the thumb on the scale for telehealth. I think we should be putting the thumb on the scale for consumer election, since that is going to be probably one of the most important indicators for appropriateness of care and network adequacy. So I think a blanket credit is just not appropriate and not going to be indicative of network adequacy. But otherwise, I really appreciate all the work you've all done on this and the creativity with trying to find a solution to integrate telehealth. I just think, as Ms. Weber said, I think we already have a solution and I don't think it needs changing. So I appreciate you taking the time to listen to me.
Thank you, Ms. Burgin. Does anyone at the MIA have any questions? Okay, we can move on to our next speaker then. Right now we have Allison Taylor, Director of Government Relations, Kaiser Foundation Health Plan. Welcome, Allison.
Hi, thanks, David. For the record, my name is Allison Taylor. I'm Director of Government Relations for Kaiser Permanente in the Mid-Atlantic region. First of all, I wanted to say thanks to you all for the really thoughtful work you've done on this. As a former staff person and the agency, I know how difficult it is to take in a lot of comments and really consider them all. And it's very, very clear how much thought has been put into this. So it's much appreciated. Kaiser Permanente is an integrated delivery system. As many of you know, we provide most of our services through our exclusive contracted provider network, the Permanente Medical Group. So we have been collecting a lot of data on telehealth ever since, well, before the pandemic and after the pandemic too. And so for any of the advocates here, anyone who'd like to talk to us offline about our telehealth offerings, we're always welcome. We're always happy to do that. I just have a question for the MIA today, and that is if either now or at some point in the future, you could provide a fact pattern to carriers about how to apply the telehealth credit for waiting times. Reason for this question is, as instructed in the regs right now, for the travel distance standards, it's fairly prescriptive under certain circumstances. For example, you'd get a 5-mile credit. or whatever. For the waiting time standards, it's saying it's up to a 10% credit. And so what just wanted to understand what was meant by up to. When would we be requesting 10%, when maybe less? So if you don't have something right now to respond to that, just at some point in the future, we just would want to make sure before we got to work on our filing that we really understood what you were looking for from us. And that's it for me. Thank you.
Thank you, Allison. Yes, and we'll certainly look more at clarifying the telehealth credit for wait time and what was intended there. I don't have an example I can run for you right now, but we'll definitely look at that more closely and provide clarification on that issue. Does anyone else from the MIA have any questions for Allison? Okay, well, thank you again. And we can move on to the last of our registered speakers for today, and that is Matt Gelentano, Executive Director of League of Life and Health Insurers. Welcome, Matt.
Thank you, Associate Commissioner Cooney, and thanks to the entire MIA team for the opportunity. I have submitted written comments, and so have, I think, all of the other carriers operating in the commercial market in Maryland, so I'll try to remain brief. I really appreciate the collaborative and transparent process. As you know, we are committed to improving access for beneficiaries and remaining accountable for network sufficiency. That being said, there are a couple of concerns that I laid out in more detail in my letter about some of the provisions that the carriers feel like will be committing resources to for compliance requirements, where we could be using those resources for innovation to address some of the challenges. So overall, that's just sort of a basic concern. And I have four things I sort of want to touch on. First is that we are interested in the timeline for implementation. Associate Commissioner Cooney, as you know, carriers are already collecting data for the 2023 filing. And there is angst amongst our members that we could not do this by July 1, 2023, and sort of officially requesting a delayed implementation time. We want to do it correct. We want to make sure we have all the requirements set to give you the best information that you guys need. As to data and claims that's sort of recurring throughout the new regs, we believe there's already a healthy amount of data flowing through APCD, and some folks are concerned about the additional administrative burden. I mean, I've received a lot of different comments that there's enough existing utilization data that we don't need to have new data pulls. And those new data pulls are going to take a lot of time away from some of the innovation that carriers are committed to and have been trying to advance in the last couple of years. And we still sort of have an overall concern about the wait time section in general, and especially the survey response part. We're just worried it's not going to be effective. Without a provider requirement for them to fill out their surveys, we think they're just going to ignore it. And without them having any sort of skin in the game, we don't think we're going to be able to get further along on that process. There's also a bunch of nuance that we've talked about as a wait time metric in general that I won't go into now, but we'd love to continue the conversation about how we can best address that section. And then lastly, we are really thankful for the 10% credit. We think it's appropriate, especially given the world that has sort of modified since not only the pandemic, but since 2014 when carriers started using telehealth. And we appreciate the ability to sort of capture that modification and the innovation that's within that marketplace. We're still scrubbing a few parts of how it relates to other states, but we want to keep discussing that portion as well. Lastly, in the telehealth section, I have to address some of the comments I heard earlier from a couple of the advocates. And what I'm hearing is that they want carriers to be required to provide payment and coverage across the board, but we shouldn't get credit. And it feels like we're hearing we can't have it both ways. I've heard carriers should get the credit, and then in the same advocate's testimony that we shouldn't get it. I just don't understand how to address that. And I just want to remind folks that the carriers were one of the main ones that was suggesting during the discussion of telehealth during the Senate Bill 3, House Bill 23 discussions, that we were the ones suggesting that we would be getting better healthcare outcomes with in-person visits. So to paint the carriers as the folks that are trying to steer folks into telehealth is incredible. No one's steering anybody to telehealth only services. That was also suggested. There are telehealth only products to respond to the marketplace that have popped up in the last couple of years, but to imply that we are the ones that are trying to skirt the rules of network adequacy is flabbergasting. And there was also a lot of accusations with no basis from before that continue to be a source and fit a pattern of misinformation that have gone along in these discussions for years and years. And it's very frustrating. But with all that being said, we're going to remain to be at the table. We want to continue to be back and forth. We'd love to have some further conversations with the MIA team to make sure that we get this right. And I really appreciate the opportunity. Thank you, Associate Commissioner Cooney.
All right, thank you, Matt. Does anyone at the MIA have any questions for Mr. Gelentano? Okay, well, Matt was the last of our registered speakers. At this time, if there is anyone on the public link of the call who would like to provide comments, if you could use the chat function and raise your hand, and our staff can move you over. Suzanne, has anyone requested to speak during the course of this meeting so far?
Yes, we have Chris Hathaway.
All right. Are you able to unmute her or move her over to the panelist role?
Yes, Chris, are you able to speak?
Can you hear me?
Yes, we can hear you.
Yes, we can hear you.
Great. I'll just take a moment and thank you so very much for allowing interested parties to speak. Apologies for not joining the regular podcast. So I just wanted to parallel some of what Matt had mentioned, Chris Hathaway with America's Health Insurance Plans. I just wanted to, and also hope that Commissioner Burgin, you're feeling better soon. If it makes you feel any better, I just came from where you were, and my team is not feeling sick. So I'm hoping it's something other than where we all kind of go and lean towards. So my hopes are with you. So I did just want to mention really quickly from a national perspective, we did kind of reach out to our California plans. You've done a survey that is similar to California. And Commissioner Burgin, I know you know Commissioner Lara, maybe if you could reach out to him and his team or staff, just to kind of a little bit maybe more information. We've reached out to the California plans, and from what they've said on the survey is they're not getting a lot of feedback from their member plans. And when they've reached out to the CDI, they haven't gotten any kind of justification about how things should change, how they should maybe be altered, maybe how do we get more engagement. And this is not it is California, so they're higher numbers, but one of our plans spent over $1 million on this survey. So we're just trying to make sure that we're, if we're moving forward on this, how do we do so in a proper way so that way we're getting the best results we can. So just thought that would be a recommendation maybe before moving forward on that, to really kind of reach out and try to get some best practices that may be more helpful. We've done that in California, haven't gotten any feedback, but you may have better luck. So just wanted to put that out there, and thank you all very, very much for your time.
Thank you, Ms. Hathaway. Does anyone have any questions? Okay, thank you again. Suzanne, has anyone else requested to speak?
I do not currently see anyone. And I do not see any raised hands.
Okay, thank you. Commissioner, is there anything else you wanted to say?
Just briefly. So again, I apologize for not really being able to participate well, but I have listened the entire time. We will take all of the comments that we've received in writing so far, the comments that we've heard today, the ones that will come in for the rest of the day under advisement. We'll think through them very seriously. We have and will continue to engage with our fellow regulators and with CMS as we develop our approach to this. The only substantive comment that I will make without having suggested that we've made up our mind completely about the right approach to this is that I do not want to conflate the distinction between assuring consumer control over their health care and the ability to determine along with their provider when telehealth is appropriate in any setting most particularly a mental health setting. I don't want to conflate that with how we measure network adequacy, because those, in my mind, are two different things. And we have to look more broadly at network adequacy, in my view. And if we require specifics around each consumer's ability to make that decision, I don't really know how we bring that into a measurement matrix. So I'm not inviting comments on that right now. I know there have been a lot of comments submitted, but that is an area that we internally as a team have spent a lot of time trying to think about and talk about how we do not disadvantage anyone's decision, while at a macro level and the aggregate looking at what adequacy means and how telehealth advances that. So I just wanted to throw that out there because we are deeply mindful of and respectful of individuals' self-determination along with their healthcare provider about the best modality of care for themselves. So with that, let me just say, again, thank you to everybody who's participated, for your thoughtfulness, for your comments, for your courtesy as we work toward building consensus here. And then David, I'm gonna let you wrap this one up.
Sure. Thank you, Commissioner. And I do see that Deb Rifkin has now raised her hands from Care First. Suzanne, if you want to move her over.
As she has been moved over.
Deb, we can see you, but we can't hear you.
How about now that I
There you go.
unmuted? So I'm sorry, I was having, as you can see, I have technical difficulties. I couldn't get myself over in time. So I'm sorry I am after the commissioner, but I just wanted to say a couple things. One is we have submitted written comments, I think based on some of the comments we heard today, and and in addition to that, what we asked in a number of places, Commissioner and David, is if we could get some feedback from you all on how you think you're going to implement certain things, similar to what I think you heard one from Matt about how you were going to, assess something. We ask in several places. I think based on that reaction that we get from you, or if we could have a conversation with you, we may then have additional comments. And so I think we tried to be as comprehensive as we could in the first place, but we did ask several questions that may elicit additional thoughtful responses from us. The second point, which is an overarching point, is I just wanted to say publicly how disheartened I am with the comments I've listened to today on telehealth. And to the carriers who, and I can speak for Care First in particular, we are trying to come up with as many novel ways and reasonable ways to ensure that our members have the best access possible to providers in our network. We see, and I think the legislature, based on the strong support from almost virtually every provider in the state and every provider organization, that telehealth was extremely important and was as valuable as an in-office visit, as long as the provider, and the patient and the carrier all had that as an option and not necessarily as a requirement. And that's what the carriers have tried to do. It's an option, and it's an option that works for some and not for others. To me, it's no different than a provider that has 4 different offices that you can go to see that provider. You don't have to necessarily go to the one on Main Street. You may be able to go to the one that's on Elm Street as well. This is one more option for that that has been shown in the law to be something as of now, and that's being evaluated to be as the quality as good, because we're required to provide it and pay for it the same as an in-office visit. And it just is very disappointing to hear that that is not, as long as it's an option that the carrier is providing, the same as an in-office visit. And so I appreciate greatly the fact that you looked at other models and you found Medicare Advantage and Medicare as an option to what they're doing for their population, and that you modeled after something that's already out there. So I thank you for that. I think it makes a lot of sense. It's not, it's a portion of this. It doesn't replace in-office visits. So I really appreciate what you did, and I think it was a very balanced approach, and I just wanted to thank you again.
All right, thank you, Ms. Rivkin. Did anyone at the MIA have any questions? Okay, Suzanne, I'll ask one last time if there's anybody else who raised their hand. Okay. Well, once again, I thank you, everyone. We really do appreciate, everyone is obviously clearly very passionate about a lot of these issues here, and it's been very helpful, these discussions over the past couple of years. We do really want to work towards finalizing these as soon as possible this time. And as I mentioned, or as the commissioner mentioned at the top, the deadline for the written comments was extended to close of business today. So if anyone has any follow-up comments they still wish to submit, please do so. And we will be taking all those comments under consideration, and we'll be looking at our next steps from there. So also the recording. Oh, yes, Commissioner, please.
No, I was just literally waving goodbye.
Okay. Well, thank you, everyone. And the recording will be posted to the website in the next few days. So thank you once again. Have a good day.